help to address a longstanding issue with timing during arrhythmia, as well as the general function of a balloon pump in a high-risk patient in a challenging OR environment. Now, I will also review the physiologic effects of the balloon pump when timing, triggering, and volume delivery are optimized. I do work for Teleflex, so I am a paid employee. Now, balloon pumping has been established therapy for compromised left ventricular function for almost 50 years. And the main effects of the balloon pump occur due to volume displacement using the principle of counterpulsation. When the balloon pump is correctly synchronized to the cardiac cycle, it should result in afterload reduction and diastolic augmentation, which may enhance coronary and systemic perfusion. Patients in heart failure and other conditions seen today are prone to arrhythmias. We all see it every day, which produces unknown and potentially detrimental effects on the LV. Now, new studies demonstrate how balloon pump timing affects LV performance from the pressure-volume plane. And the findings will be reviewed to enhance clinical knowledge of the benefits of correct timing and the possible negative effects of timing errors. A new timing method for intrabeat inflation will also be presented today, along with the results with clinical study of this method in cardiac surgical patients. Now, today I want to focus on the 4 following technologies available in the Aero AutoCat 2 Wave and the AC3 Optimus balloon pump systems. Our 3rd generation autopilot mode is going to perform 4 main functions for you. Autopilot mode will automatically select and change ECG and AP sources, including the leads for you. Now, you as the user can select the ECG and AP source, which autopilot will accept as long as signal quality is acceptable. Next, for autopilot, we will select and change the trigger mode based on signal quality and patient condition, heart rate, patient's arrhythmia, things like that. Autopilot will also select the timing method based on available signals. And within the Aero systems, we do offer 6 timing methods. There are 3 inflation and 3 deflation methods. Wave and R-wave inflation and deflation provide real-time intrabeat timing, and they are going to be selected when appropriate. Autopilot, last but not least, will adjust and update timing settings based on the timing method selected. Now, the next technology to review is our fiber optic arterial pressure waveform signal acquisition. It provides a real-time, high-fidelity AP signal. Now, this activates our wave inflation timing algorithm, which can increase the support from the balloon pump anywhere from 60 to 90 minutes per day. Next, wave timing uses our Windkessel model to convert aortic pressure to flow, and the inflation is set at a specified point on the flow wave, which is synchronized to aortic valve closure. And last but not least, finally, when an arrhythmia is detected, the pump assesses the time available and the time needed to deflate the balloon at least 70%. Now, the deflation timing method is selected based on this algorithm, and the assessment is dynamic as long as an arrhythmia is present. Now, we start to look at our pressure volume planes and really diving into what we want and expect a balloon pump to do for our patients. The first PV loops show, you can see it's the taller, skinnier, and I apologize, the video on this slide is not working. So the first PV loop shows the impact of the balloon pump on LV function with optimal support, meaning proper timing, full volume, and one-to-one assist. Now, this shows the effect of the balloon pump is immediate within the first 3 to 4 beats. So the change that you're looking at is going to change that PV loop to shorter and wider. That's going to show us that decrease in pressure and an increase in stroke volume. So we're moving more volume easier. Hemodynamics should be tracked over the first 30 to 60 minutes to assess the effect for the patient, but the impact on the LV is immediate and predictable from the first beat of the pump. Now, this effect is also consistent and predictable in all patients. While the amount of change varies based on patient condition, the type and direction of change is consistent in all who were tested. However, in patients today, the presence of arrhythmia, especially irregular arrhythmias, has increased. And the big question is, how will the pump perform in the presence of this type of arrhythmia? Now, going back to our example of timing during arrhythmias, the question is always, is this helpful or harmful to our patients? And in this case here, you can see that only 3 or 4 beats were properly assisted, with 11 early inflations and 8 early deflations, in there. Now, based on the data from Schroeder, we would conclude that this timing was probably more harmful than helpful to the patient, as the combination of early inflation resulting in reduced stroke volume and increasing end systolic volume and pressure and early deflations, which did not reduce afterload, would compromise LV function rather than improve it. Now, once the impact of optimal balloon pump support was tested, we tested timing errors, and the first being early inflation. Now, here you can see a drastic change in that pressure volume plane, and in early inflation, the increased pressure in the aorta causes regurgitant flow back into the left ventricle, causing a rise in left ventricular pressure and a premature closure of the aortic valve. Now, this immediately reduced stroke volume and impacts LV relaxation, which reduces filling of subsequent beats. Earlier inflation results in a greater loss of stroke volume due to that premature closure of the AV valve. This increases, again, end-systolic pressure and volume, and over time may result in worsening heart failure. Now, this timing error also is going to increase MVO2 due to the increase in wall tension and increased volume and pressure. Now, late inflation reduces the length of augmentation, but does not result in immediate negative hemodynamic changes. Now, over time, the reduction in coronary flow may be detrimental to balancing oxygen supply and demand, but we did not specifically study that here. We wanted to stick with what we knew was bad and look at that early inflation. Now, overall, when we look at the full study findings, we really group them into variables by general systolic and diastolic. And variables studied are shown on the slide, and the top section where the table is, that's really just a single snapshot event. The key findings for the full study are down below on the bottom half of the slide. Now, overall, the average improvement in stroke volume is 16% with correct timing, 1-to-1 assist, and full volume. And EF increased by average of 14%. Early inflation reduced stroke volume and ejection fraction by 20% on average due to, again, the abrupt closure of the aortic valve and regurgitant flow back into the left ventricle. This increased the end-systolic volume and pressure acutely. Now, tau, or LV relaxation, is also impaired, which makes the LV stiffer and may impact filling on future beats. Overall, the loss of stroke volume and ejection fraction with one early inflation beat is not made up by one normal beat. And over time, this may result in worsening heart failure and LV performance. Now, we break into a case report. The purpose of this is to review the principles and performance of several new balloon pump technologies in the OR setting. And the case took place in Milan, Italy at San Raffaele Hospital and was performed by Associate Chief of Cardiothoracic Surgery, Dr. Taraka. They do a large number of cardiac surgeries at this facility, and on average, they do use about 180 balloons a year, so large facility. This slide, we also are introducing our WAVE investigator team, led by Dr. Jan Schroeder and Professor Alfieri here. Now, just the case study, just kind of basics. The patient in this case was a 57-year-old male with severe mitral valve disease, pre-infarction angina, and poor LV function. EF was rated about 25%. Surgical procedure that was planned was a mitral valve repair, CABG ×3, and the case was to be done on bypass, and a balloon pump was planned to be used. Due to the patient's poor condition and a high risk of mortality, shown here with a Euro score greater than 16%, pre-op balloon was planned. We expected to have arrhythmias in the OR, low cardiac outputs, interference from devices used in the OR, your normal daily life. And the case will show how new technologies were able to perform under all of these conditions. Now, the catheter that we did use a 40 cc fiber optic catheter from Arrow. It was a sheathless insertion to the right femoral, and position was confirmed via TEE. Balloon pump system was used AutoCAT 2 Wave. We did use autopilot during the case, and all data was collected via an external PC connected to our pump. Now here you can see the third waveform here is our flow wave, and that's going to be calculated based from our wave algorithm. But what you can see is that an auto zero occurred 12 seconds after connection to the pump. And with the Arrow systems and our fiber optic catheters, it is a true atmospheric zero prior to insertion. So there's no calibration done to replace that zero. It is a true atmospheric zero prior to insertion. Fiber optic catheters, the big question is, why do we need them? Why do we use them? Well, the most important reason is that the fiber optic catheter from Arrow is going to reproduce the arterial pressure waveform in virtually real time. This resulted in an average increase of an hour to an hour and a half more balloon pump support over a 24-hour time period. This simply occurs due to the loss of the delay of the fluid pressure monitoring system. Now, in addition, the sensor is unaffected by electrocautery, patient movement, tubing length, air bubbles, all those normal things we're used to. And fiber optic balloons from Aero do have a fully functioning central lumen for monitoring the AP source from the same location as the FOS sensor. This can be used to verify accuracy. Now, this slide here is going to show some of the advantages of the fiber optic signal, and the fiber optic signal up here is going to be the blue arterial waveform that you see. The red arterial waveform is from a standard fluid transduced monitoring system. You can see that the fiber optic signal is a lot clearer, the dichrotic notch is visible, and the readings end up being more accurate simply because the fluid-filled transducer was not properly positioned. And we all know that can have a big impact on what you're actually getting in hemodynamic monitoring numbers. Now here when we started the pump, you can see you have very quick startup and with optimal support in autopilot mode. The automatic trigger selection, timing method, and settings were done for us because again, we were in autopilot, and the pumping starts at full volume and a 1-to-1 assist. Now, timing of inflation and deflation is accurate from the very first beat, and we are seeing about 20 millimeters of mercury augmentation rise and good LV unloading. Here, this is an example of the aortic flow calculation from our WAVE algorithm. WAVE stands for Windkessel aortic valve equation. And the flow is calculated from the arterial pressure waveform occurs, so it is in real time. Now, peak flow always occurs before peak pressure, and we know the aortic valve closes at the lowest point of flow after the peak. By knowing how long it takes to inflate the balloon, we can use a percentage of the descending flow to start inflation before the aortic valve closes and have augmentation pressure rise as the aortic valve closes. A question that we get a lot of times is, how do you update your timing with this? Well, this shows how timing is set and adjusted within the beat as each beat occurs. WAVE calculates flow where peak flow is relative to peak pressure, and timing is then set when the descending flow point reaches 15% after peak flow. Since each peak flow is relative to peak pressure, the 15% point varies with each beat. Hence, timing is set for each beat specifically as that beat occurs. So it is truly an intra-beat timing, and it only looks at that cardiac cycle that it's working with because it's looking at the flow of that single cycle. Now this example here, you can see that we see the flow calculation and inflation of the balloon occurs when we reach 15% after peak flow. So if you look at that aqua arrow on this slide, that's what it's showing you. You can also see here that the red fluid arterial pressure waveform signal is very dampened, which would make timing difficult when fiber optic signal remains very strong and very clear, able to be used well. Now, new research that I want to highlight is from Dr. Garacino out of Pisa, Italy. And what he's been studying is the effect of wave inflation timing on coronary blood flow velocity with real-time inflation and deflation. So on the Aero pump, that's wave inflation and our R-wave deflation. TEE was used to measure beat-to-beat coronary flow and myocardial strain, a measure of contractility during balloon pump support. Now, AutoCAT2 wave with timing and R-wave deflation did increase coronary blood flow by 28% over conventional timing. Remember, conventional timing is predictive. Look at past beats, set the timing, and apply it to everything coming in the future. Now, the benefit here is due to the precision and consistency of the delivery of the augmentation wave within the physiologic window. As a result of improved coronary blood flow, myocardial strain, or the force of contraction, is also increased. Coronary blood flow should be kept constant beat to beat, as this produces the best improvement in strain or contractility. Now, while the Schroeder studies focused on the acute effect of the balloon pump, which was documented to be the unloading effect, Garacino's study reminds us of the importance of augmentation to improve coronary perfusion. Now, this slide here shows the TEE trace during no balloon pump support, and what we're really looking at is the orange waveform up there, and flow below the line shows us coronary blood flow. The bottom two traces are going to show myocardial strain. Now, top is the actual contraction, and the bottom panel is the percent change in strain. The top panel here, we look at the length of contraction, so that top graph, and in the bottom graph, we're going to look at the peak differences, so the high to low. That represents the contractile state. Now, this slide is shown as the baseline for balloon pump support. Now, when we move forward, this slide shows 30 cc balloon at full support, And in the top panel, you can see the increase in coronary blood flow below that line. So again, looking at that orange waveform. This is blood flowing toward the TEE, and compared to the last slide, there is a significant increase in coronary flow. In the second panel, you can see that the length of contraction is similar, mainly because the heart rate stayed about the same, but the peak-to-peak strain has increased, which indicates a more forceful contraction. This would result in improved stroke volume in an EF and cardiac output. Now, back to our patient, back to our case study. Electrocautery was applied here, and you can see that the pump switched immediately to arterial pressure and continued accurate support. But even with the switch in triggers, consistency and timing remains. And this is a crucial piece to therapy results, as proven by Garacino's research, showing the importance of both accuracy and consistency of that inflation timing. Now here you can see that the fiber optic signal remains nice and stable, while the transducer has become very dampened, and the pump would not have been able to trigger or allow the user to set timing on that fluid-filled waveform, but the fiber optic remains stable and available for good timing. This slide here shows the fast reactions and acute and accurate timing during early unexpected beats, normal scenario that we see all the time. And here you can see that the patient's rhythm actually went irregular, and the pump began the deflation timing management program to determine if there was enough time to deflate the balloon on the R wave or not. Now, this program compares in the Aero systems balloon deflation speed to the time available to deflate the balloon. When 70% of the balloon volume can be removed prior to the next systole, R wave deflation can be selected. Now here you can see deflation timing management determined that the R wave was acceptable and AFib trigger was selected, and the patient did go back into a regular rhythm. However, the pump did continue on with that trigger because it was safe for the patient. Now the question then is, what kind of timing errors can we have in an arrhythmia with predictive timing? So we looked at, again, our pressure volume plane, and when R wave deflation was tested, there was a two-part impact, so late deflation. First, isovolumetric contraction was lengthened due to the balloon keeping aortic pressure higher during early systole, and this does result in an increase in MVO2. However, as the balloon actively deflated during systole, the timing resulted in an increase in stroke volume in most patients. This finding supports the earlier research, which concluded that while there is a benefit, i.e. increased stroke volume, there's also an increased risk, that being an increase in MVO2. Now, like late inflation, early deflation did not reduce the length of isovolumetric contraction and therefore did not result in afterload reduction. This results in LV performance being at the same or similar levels to unsupported beats. And while this may not be detrimental to the patient, the risk of using a balloon pump may not be justified if the benefit is not present. Now, looking a little bit further in our deflation timing management with the Aero systems, when an arrhythmia is detected, the balloon pump chooses our peak trigger to allow the earliest trigger detection point. The pump then measures the time available for deflation, PEP phase, the distance from R wave to AP upstroke, and the time needed to achieve at least 70% deflation of the balloon catheter. So we don't want anything more than 30% residual volume in the balloon catheter at the start of systole. Therefore, it would be causing a late deflation. Now, the pump assesses the measurement for a total of 60 beats, which depending on our heart rate can vary anywhere from 30 seconds up to a minute maybe. And if there's enough time to deflate the balloon, at least 70%, the pump will select R wave deflation or our AFib trigger. If not, it will remain in peak trigger, which allows deflation to occur earlier. This assessment is continuous when an arrhythmia is present, and the decision of the deflation timing method will update based on the current conditions. So again, it's a dynamic assessment continuing as long as the patient's in an arrhythmia. This slide here just illustrates the two measurements of PEP and the balloon deflation time and essentially what is needed. And when we come back to our patient here, our timing continues to be stable with the wave algorithm despite changes in both heart rate and trigger mode. So you can see we've varied between triggers throughout this case as typical, but now we're gonna go ahead and take a little bit of a break so we get to go on bypass. And as we wean from bypass, the patient did need to be atrial paced, but autopilot detected the pacer spike as we expected it to, and timing remained accurate with that fiber optic signal. Now, the patient's own rhythm did return, and timing continued to be accurate, and he was well supported by the balloon pump. Now, in conclusion with the case report, so this case shows the ability of new pump technologies to support a high-risk patient during cardiac surgery. And the patient remained stable during the case and was weaned off the balloon pump on post-op day 2 and discharged from the ICU on post-op day 3. Cardiac index and other hemodynamic markers indicate that the patient was adequately supported during balloon pump therapy despite many changes in the patient condition. So when we talk about balloon pumping, we talk about timing. It's always, does timing accuracy matter? Now here we're gonna look at a comparison of optimal balloon pump assist to 50% assist. And the big question is, does that matter? And when you look at this is a patient from our WAVE study group. And this is just a quick snapshot of that patient. Now the PV loops on the left show the inaccurate timing, which is equivalent to about 50% assist versus the PV loops on the right, which show the LV performance when timing is stable. You can see there's a big difference between the uniformity there. And this is an example of the difference in LV function with proper balloon support as compared to less than optimal. The PV loops on the left, you can see the contractions are less uniform, indicating less efficiency, while the PV loops on the right, they are more uniform, indicating better LV function. The timing in this example on the right is using WAVE and R-wave deflation, so it's truly automatic beat-to-beat, intra-beat timing. While there is still some variation in stroke volume on a beat-to-beat basis due to rate and filling time changes, the overall contraction of the LV is more uniform with fully timed inflation and deflation. Now, to conclude for today, we have confirmed that the balloon pump produces an immediate and predictable improvement in LV performance within the first 3 to 4 beats of properly timed full assist support. This is due to the acute afterload reduction, which reduces mechanical desynchrony. Arrhythmia results in incorrect timing when predictive timing methods are used and reduced in the effectiveness of the balloon pump. And because of this, current balloon pump systems using predictive timing methods perform suboptimally. Early inflation, we all knew it, confirmed now is the worst timing error, resulting in the greatest compromise to LV hemodynamics. In real-time timing technologies, improve balloon efficiency and are especially important during arrhythmia, although they do provide benefits to all patients. Lastly, here on the left panel, we have a predictive timing in a patient with an arrhythmia. The right panel is the same patient about a minute later with wave inflation and R-wave deflation. The accuracy and the consistency of timing is what offers a significant impact to the LV function and performance. Now, the question we most frequently get is, do balloon pumps still work? Unequivocally, yes, and today's discussion has shown the positive impact to our patients when therapy is optimized between volume delivery, assist ratio, and the accuracy and consistency of the timing of inflation and deflation. Whether it is right for your patient is a different question. Any questions? Thank you. All right, thank you. Oh, maybe question? Oh, so close.
Go ahead.
You can't get off the stage that easily. Jeff Riley, thank you for your excellent presentation. I thought the statistic, you can gain as much as an hour and a half of support in a 24-hour period. I can tell you about all the times you stood in front of the machine waiting for it to collect itself and start supporting again. So I think that's a big deal. Mm-hmm. This is a little bit off your topic. Is there an optimal timing for balloon pumps during ECMO, during VA ECMO?
What do you mean optimal timing? Timing as in inflation, deflation timing? When
Good
to
for the
use?
left ventricle. Decompressing the heart. Good for the left ventricle. That's a tough question.
That is a tough question. I think it would probably be patient specific, honestly, really to look at how much distension you do have on that LV and whether they do need that assistance. Do you mean instituting therapy, kind of beginning therapy? You should always want to be synchronized to the cardiac cycle. So if you do have a stable EKG, that is ideal. That way, if there would be any kind of outflow from the LV natively, you're already going to be synchronized with it. And if you're weaning that ECMO device, you definitely need to be synced to what the patient's doing. If, in the interim, if you don't have a stable EKG to utilize for triggering, You can go ahead and use internal trigger in the interim, but I would say be cautious with that if there is any kind of contractility from that LV. You just want to be synchronized with it.
Yeah, John Ingram. I want to follow up a little bit what Jeff just said, because my question was, if you have someone either on ECMO or on bypass that's femorally artery cannulated, and you have a balloon pump in, have you guys done any studies as to what's really going on at the coronary level when you have retrograde flow up the aorta?
Not that I have available right now.
Yeah, I would encourage people to look into that, because we see ECMO patients that first got a balloon pump, then they put them on femoral artery cannulation. So what's really happening? It may even be detrimental, in my opinion. It may be. You don't know yet until we study that, because when the balloon's inflated, now you've occluded flow altogether that's coming up retrograde, up the aorta. And if the heart is not contracting, and that may be why you're on ECMO, then when the balloon deflates, do you actually have retrograde flow out of the coronary, or do you not? Because now you have a surge of retrograde flow up the aorta. So I wonder sometimes if we are actually, and I've seen ECMO patients with femoral cannulation and a balloon pump and actually felt like it was detrimental. They couldn't prove that.
Yeah.
But that would be something now that we see a lot of that going on.
Yeah, there's a lot of combined therapies out there. And one of the things that I would just like to throw out there, and again, I can't answer your question completely, but one of the nice things on the Aero systems, I don't know which pump system you have, is that you can control by half cc increments on the volume delivery. So if you didn't want to occlude as much, 85 to 90% is ideal. If you wanted to occlude less, you could go down to, a 75% fill, 70% fill. So you would have more room around that membrane in the aortic environment. So it's an option. It doesn't answer your question fully, but it's just kind of management's sake.
And the other thing that we saw with that is that since we were femorally cannulated, the balloon pump was inserted through the subclavian so that the tip of the balloon was facing down. So the reading that you saw on the fiber optic, I'm not even sure what that meant, because you couldn't make sense of the pressure tracing, because the reading was facing the retrograde flow of the cannula flow and wasn't giving you anything about what was happening in the aortic arch. So it was interesting to see.
The fiber optic transducer on the Aero catheters is actually on, the metal tip of the balloon. It's actually on the side of the catheter, so it's still getting the same kind of flow past it. I can't go too far into a subclavian because it is off-label. So, unfortunately.
We have someone that's asking about the trends with intra-aortic balloon pumping as Impella has evolved.
So Impella obviously is our first step of active assist device. Balloon pumps are passive assist. However, you should always start out with that. You should always start out more conservative and then add if you need to. The balloon pump, if you are not reaching the hemodynamic goals for that patient and capturing what they need in cardiac output and metabolic support, you can always add an increase from there. So I would say start conservative and build from there, because that does follow the true mechanical circulatory support chain of support.
Does it affect the total volume of the
Sure, of
Impella?
course. Any new therapy, it can come into play with total numbers, but it does come in pockets, and we've seen kind of fluctuations in different facilities come back. So, okay, all right, thank you.
Okay, so we're going to take a break right now. We're going to be coming back at 10:10, and please go and visit our exhibitors for a while and take a break. Get a little bit of stretch, walk around, but don't leave.
Is there a timer on?